So now we are going to begin this session, and let me call on Professor Samuel Moret. He's going to give us a very nice talk about RAS testing in Egyptian colorectal cancer patients with comparative data with Egyptian data.
Well, good afternoon, everybody. Once again, happy to be here, Chairman. I'm speaking actually on behalf of Dr. Mukhtar, because she's not here, and it's both our work. So I believe she's in Germany at the moment. So I've been told.
It's your work also.
It's also my work. So I was going to give you a brief overview as well with some things, but based mainly on the slides that she did send me. There's not much alteration. So RAS mutational testing, because we've been testing full RAS testing here for a couple of years now. You probably know this better than I do, but what I was really surprised about was the high rate of young cases, and this will become evident from the data we have. And actually, when I analysed the data, I analysed it blindly and just put cut-offs on age, and had never really thought about it until we discussed it a bit later. And of course, there's also the association with bilharzia colitis that you have, which is probably got some indication, mainly, I have no idea in reality, but maybe it's got some evidence to suggest that this is related with the younger age as well. But you'll have to tell me about this, so that's a question I'm putting to the audience really. And there seems to be a high metastatic rate in our RAS testing. Data that Nadia gave me was that the colon is quite the highest incidence for the digestive system tumours. And of course, it's standard probably across the world. It's not that much different between here and Europe, so I don't see any differences there. The data that she gave me here was that most of them are adenocarcinomas, very high incidence, 71%, and then the rest fall in, as you can see there. And of course, T3 tumours more than 40%, and 64% with liver metastasis. This is quite high compared to what I've seen just by looking across the data throughout Europe. So it was actually quite interesting data that I looked at. And of course you realise that it's a multi-stage process, the evolution of colorectal cancer, RAS being a very early event. So what we're expecting and what we see in multiple studies that have been conducted now throughout Europe and the States is that when you have a diagnosis, do your RAS testing up front. Doesn't matter. It's going to be useful later. And it's probably not going to change. And we think that the incidence is about 4 or 5% in terms of discordance. But this is probably technical more so than anything else. It's very difficult to understand so well. But 4 or 5% is not a huge difference. And you'll see tomorrow I give data for BRAF mutation in melanoma. It's 30% different between primary and metastasis. It's a huge undertaking that needs to be looked at there. But in colorectal cancer, you're quite safe to do it up front. It saves time. Simplified RAS testing, as you realise, DNA isolation, as we discussed before. 6 exons now, 3 from NRAS, 3 from KRAS, and you identify and report out your mutations. You can see it. That's good. You can see it because I can't see it very clearly. Guidelines, as I said, I work on guidelines committee, and what we would like to see is that the result is delivered to the clinician within 5 to 6 working days. So that's a standard workflow, quite compressed. It's not what really happens, because usually it takes a bit longer, sometimes it takes less, but that's what we would like to envisage that wouldn't compromise the patient from being treated appropriately. And as I said, I sit on a path board for molecular pathology, molecular genetics, and this is centralized lab data giving you an idea on the number of days turnaround, and this is for the best labs across Europe and the States. It's about 8-day turnaround from delivery of sample to the laboratory. These are not all pathology labs. A lot of them are molecular diagnostic labs that don't have any pathologists in-house, which means they have to send out for referral of the reanalysis of the biopsies before use. So you can see that there's 2 or 3 days there for pathological review or shipment between sites, and another 4 or 5 days in terms of the normal diagnostics. And of course, there's lots of issues about what to test. And this isn't just colorectal, this is in terms of everything. We discussed some of this before. What percentage of the tumour should be neoplastic? How many tumour cells should there be? What's the minimum volume of tumour cells that you can run an experiment with? Is there heterogeneity within the tumour? Within the same tumour? And that's tumour dependent, obviously. And then you come to the middle 3, and that is the neoplastic cell content and volume are important for all diagnostic tests in terms of the kits that are out there on the market, and also for your diagnostic devices. And each molecular diagnostic device has a different requirement of those. But does your kit cover the spectrum of the mutations you wish to envisage? So for RAS, full RAS testing, not all kits do this. So you can think about Cobus now does. Okay, Therascreen now does. Panagene now does. But there are some others that don't cover them appropriately. They don't cover, for example, the 3 exons in NRAS and KRAS. They cover 2 exons in KRAS and 3 in NRAS. So you miss a codon. Probably doesn't change that much the outcome because of the low incidence of those mutations that occur in those exons. But still, it's not full coverage. So you have to think about what you're actually offering at the end. Of course, pathological review is extremely important because we see about an 8% fail rate if there's no pathological review, meaning that some tumours are tested and there's no tumour tissue there at all, or it's the wrong case. We've been working on a platform at the moment. We do molecular pathology, and we cut 2 days out of our process by doing an online molecular pathology review of all slides and cases that come into our department. So we cut out our pathologist completely. He just sits at home and does it from somewhere else. We actually don't have one in-house anymore. It's not beneficial. So we now reduce our service by 2 days, and before that either the pathologist was in, which was costly, or we were shipping it somewhere else and having it returned, which is a 2-3 day process, which just delays issues. I'll just skip this now, so we're just moving on. So as I said before, we've seen this slide before a bit earlier, the workflow is the same. And in collaboration with Dr. Mukhtar from Egypt, we have cases from throughout Egypt that come through us. Our inclusion criteria is simple. Second line patients, stage 4 colorectal cancer. So all cases are second line, stage 4, as far as we understand. There are no exclusion criteria. We use 3 methodologies, and now we switched to NGS a few months ago. We've used allele-specific PCR, HRMA, and sequencing, overlapping. So some cases only use 1 or 2 techniques, some cases use 3. And Dr. Nadia has been looking at RAS by immunohistochemistry. We've screened 539 cases in the last year and a half, and I'll just give you some breakdown on these data sets. So the spectrum and the incidence. The incidence is 28.6%, so it's extremely low compared to global populations, but not outside the realms of what we've seen in other groups. We see up to 45% in some countries. But of course this is dependent on what the patient population is. This is an extremely select patient population. Okay? So stage 4, second line, you've already biased your data set, it's not just open. So to get data that matches that has been extremely difficult actually in terms of looking back and trying to get correlation. We see that most of the mutations of course exist in codons 12 and 13 of exon 2 of KRAS, and very rare outside of that, but that's standard practice globally. You can see here, sorry, it's left the page a little bit. Apologies for that. RAS incidence on the right-hand side, as you can see, is 86% for exon 2 and 13% for the rest. So this is about what we see globally. If you look at the different genotypes in the KRAS spectrum between 12 and 13. We see everything from N, R, C, and D of G13, and we see basically everything, or we found everything that exists for G12 in terms of a mutation. These are about standard. The G12V, G12D difference depends on where you go as to see if there's a difference between the two or not, but I think this is just normal noise here. I'll forget cosmic, we match that. So age, incidence by age. So if you look on the left-hand side, 18 to 49, and the brown bars are the mutant population. 60% of them have mutations in RAS. It's extremely different from what we see. I'll show you the data in a minute. And of course, the others, the 50 to 60-year-old population is probably not the best way of doing it. It should just be grouped above there, and you see a smaller population of around 20% of those patients having RAS mutations, which is also quite low. So we're catching them early. We're seeing early cases here in Egypt in terms of RAS mutations. Gender, no difference whatsoever. By site, not really that different from what we see around the globe. It changes and varies depending on the ethnicity. So I don't think this is really reflective of giving any evidence of anything different. Although the right colon being very low is of some interest in terms of pathogenesis. Non-liver to liver, you can see that those with no liver metastasis seem to have a higher incidence of RAS mutations than those with only. And this is not only. So this is grouped. No liver metastasis. It's probably not the right way to do it. No liver metastasis versus liver in the presence of any other. Okay, so it's not the right way of doing it. We should split this 3 ways. But synchronous versus metachronous tumours was quite interesting, because we see that if you have a synchronous tumour up front, meaning that you really are metastatic, it's probably you're more metastatic in this case than you are if it's relapsed after a certain second-line therapy. Then it's more likely that you'll have a RAS mutation. That fits really with what we saw before in terms of age. So this is just upfront data. Now if we look at comparison between Italy, Taiwan and Egypt, which are the 3 cases that I was able to extract data for the same patient population, second line, stage 4, not easy to get. Okay, you have a lower incidence compared to other ethnicities. We already realised that. But look at the difference in age. When you look at age, you see that again they're all young here. So there's something very different in the population, and it's striking because it also affects the older. So you imagine if you've got KRAS positive patients, they're probably not doing so well because it is a poor prognostic marker, and maybe they're just not surviving out to that later age group that you don't see, whereas we see it differently. And of course you see that with the synchronous versus metachronous as well. In Egypt, huge difference, but the rest of the world, not so much. So, just to wrap up, before we move on to the next one. So you have a 30% incidence, most of them are exon 2, which we expect. This is low compared to the other data sets we've seen. At the moment, we're putting together a task force with a couple of pharmaceutical companies to look at global incidence in all countries that we can gather data on, so we'll have a better idea of what's going on. But for this region, off record, it is lower than other countries in this region. So there's something specific about your population which is different from, for example, the Algerian population. And I like to ask the question, what's different? Why are they so young here? It's striking, it's a striking trend that needs to be investigated, because if this is true, then you've got an entirely different etiology in reality.
Other exposures, maybe.
Yes, maybe.
Pesticides, something.
Also, maybe, eating habits, what people are eating compared to lifestyle, which is different now in the last 30 years than it was 40, 50 years ago, with the older population being very different in terms of...
Is it smoking or smoking?
Smoking. I'll give you a quick. Can I just have one more minute and then we'll wrap this one up? Thank you. I had spoken to the Nobel Prize winner for HPV, Husmeiser, and he's been investigating this for a number of years. He's been looking at RAS incidence as well. And he says that if you go back 40 years until the Second World War in Korea and in Japan, before they ate meat from beef, from cattle, there was no RAS mutations, and you can look at data sets from then. There's no RAS in any of the patients from then. Now they have the same incidence of colorectal cancer as the West, and they also have RAS mutations.
I think WHO declared that for every day 50 grams of processed meat, there is increased incidence of colorectal cancer by at least 15% already.
Yes. Well, I'm okay. I'm vegetarian.
Sorry. Okay. Anything else? Any other questions?
50% increase in colorectal cancer after increasing the consumption of meat, but not increase in the early onset colorectal cancer.
Exactly.
So this has
So
nothing
you still have an early onset.
young onset.
Yeah. But that might, as you just say, it's just a lifestyle change from what we were doing before. Yeah, before you than what we're doing today.
Okay. Next. I'm coming back.
Yeah. Okay, so thanks a lot to Professor Samuel.
Next speaker is Professor Habashi. The talk will be on molecular testing in diagnostic cytology, clinical application, and